This original WSRE presentation is made possible by viewers like you. Thank you.
Hi, I'm Dee Dee Sharp, and welcome to this special edition of The Aware Show. We're glad to have you right there. This is a healthcare forum, and we're so happy to be bringing it to you from the campus of Pensacola State College. Are you concerned about how the new tax law and the new healthcare plan may impact your healthcare coverage? Do you understand the difference between the Affordable Health Care Act, known as Obamacare, and the new American healthcare plan some refer to as Trump Care? Will you still be able to deduct medical expenses? What about copays, deductibles, and premiums? Are you confused about what is the right health care coverage for you? Well, if so, you've come to the right place. Tonight, we host a panel of national experts who will guide us through the complexities of the healthcare industry and, in a nonpartisan manner, explain how the new American Health Care Act of 2017 and the changes to the tax law may affect you in 2018 and beyond. That's just ahead. We'll introduce you to our guest. First, we have some background information we want you to consider. If you remember, the Affordable Care Act, or Obamacare as it was called, was signed into law in 2010. Now get this, the national uninsured rate plummeted from 48 million people to 28 million in just 6 years. Florida had the highest exchange enrollment in the country at over 1.7 million people. But while the ACA may have lowered the number of uninsured, critics say federal mandates increase the cost to individuals, families, and businesses. In October 2017, President Donald Trump signed an executive order in an attempt to repeal and replace the ACA. It is called the American Health Care Act of 2017, and it is designed to increase competition and choice. But critics say it offers fewer benefits and less consumer protections. Well, the new Health Care Act also comes with new tax provisions. So even though the health care portion may not impact you, changes to the system with taxes could impact businesses who provide health care insurance coverage to employees and the type of health care plans that individuals choose for themselves. Well, tonight, we'll shed some light on these tax implications for you, and we'll also make you aware of what the new executive order means for you, and we'll let you know what you need to know to make the best health care coverage for you and your family in your decisions. And here to help me with all of this, to unravel it and much, much more, are our guests. They are leading experts on the healthcare delivery system and industry. All the way from New York University's Langone Medical Center, we have Andrew Rubin, Vice President for Clinical Affairs and Ambulatory Care. Next, we have Matthew Penziner, Executive Director for NYU's Physician Network and Clinically Integrated Networks. And last but certainly not least, we have Allison Vogel. She is the Vice President of Managed Care. Andrew, Matt, and Allison are all the host and co-host of HealthCare Connect that airs on Sirius XM Doctor Radio program. We want to welcome you all for our show. We're glad you could be here. Glad you made it safely.
Well, it's good to be back.
We're just going to dive right. Yeah, we did have you, and we do have you back because you all were so wonderful. You provided a wealth of information on healthcare for our audience that we wanted to bring you back with all the changes that came up, and we want to kind of make them aware of what this is going to do or may not do. So we're glad that you were able to come back to us. We're going to start by just diving right in, and just want to kind of start with right there. What's the difference between what we had with the ACA and what we have now with this act that was just passed in this executive order by President Trump?
Well, so it's been 6 years since we've been here, and as your opening remarks pointed out, there are a lot of Americans who are getting their health insurance now that previously did not have health insurance. The exchanges over the past 6 years since we first talked about it with you, are fairly strong in terms of enrollment numbers. But as people have read and heard on television and radio and seen in the newspapers, the insurance offerings throughout the country, depending on where you live, the markets are not very stable right now. So what we're seeing is a healthcare delivery system in terms of healthcare insurance and healthcare access that needs a lot of work. What we've been talking about the past year in Washington is whether or not it should be scrapped and we should start over, or whether or not we should take what we have, what President Obama and Congress back then signed into law, and repair it and make some needed structural changes. Allison, Matt, and I want, of course, them to comment on this. We try and take a nonpartisan look in how this is playing out across the country. And we are very public and open in our saying that we believe that for all the flaws of the current system and the structural problems that are out there that need to be fixed, that we're going to talk about for the next few hours, we believe that's a more practical way to move the healthcare system forward. One last comment is, what people forget and fail to remember is that before Obamacare, before President Obama, before President Bush, for 20, 30 years, healthcare costs have been rising in this country. There was never any notion or belief, at least on the experts' part, that healthcare reform would stop premiums from going up or healthcare costs from going up. I think we said 8 years ago on radio that the best we could hope for is that they would slow down. The growth in expense would slow down. And in fact, they have. Unfortunately, with the instability in the marketplace in the past year, it's gotten worse. And again, we'll talk about that tonight.
Yeah, I think the thing I would add is uncertainty, right? It doesn't matter how you look at it or what angle you look at this from. There's just uncertainty, whether you're a health insurer, a business, a hospital, or an individual. There's just uncertainty in what's going to happen this year, next year, how you're going to get your health care, how much it's going to cost you, and that leaves people really uncomfortable. And unfortunately, for a lot of these issues, there's no answers yet. So what's different? Well, there's a lot different, but there's also a lot of unknown.
And I would also add that with the Affordable Care Act, one of the most important changes that came with the Affordable Care Act, the protection of not being able to lose your health insurance if you had a pre-existing condition, or not being able to be dropped if you had high health care costs. If you had a very sick year where you had, God forbid, you got cancer, or you had high health care costs, you had a disease that cost a lot of money to get treated, and you go into remission or whatever your costs were, your insurance company at one point in time could drop you for that reason. Part of the Affordable Care Act stopped that, and that is one of the best things that came out of the law. And that's one thing that has been put forward that they want to take away from in the future as been in play. And that's something that a lot of people need to really take into consideration and understand, that all of the protections that were put into place in the Affordable Care Act, to lose that in the future is something that is really something that would be a tremendous loss to our society. I think that we really need to be conscious of that. So I mean that's one of the things that it was a gift to the American public as part of the law of the Affordable Care Act.
Okay. One important point that just to make sure people understand is those protections do exist today.
They do.
Right. So that did not change. We'll talk about some of the changes throughout the evening of what happened in the past year and what went into effect with the new tax law with the individual mandates. But the insurance markets are still open. You still can't be denied for pre-existing conditions. And what we want to talk about tonight are some of the expected changes that are coming down the road that have the potential to destabilize the insurance markets. They won't eliminate the protections that people have, not today anyway, and not what's in the law of the land today. But new offerings that the president has allowed to be sold on the marketplaces, shorter-term policies that aren't sold for a year, some that are currently sold for 90 days, association plans. These are words we'll talk about this evening. Those plans are new to or will be new to the insurance exchanges, and they don't offer the same protections that Allison was just talking about. But I don't want any of your viewers or the studio audience to be concerned, because what's in place today is what was in place last year, and those existing protections are still in existence.
Okay. When we talked at the top of the show, and I did the open just a few moments ago, we talked about what critics say about both of these right now. And with one of the main issues with ACA was everybody's concern with the federal mandates. We'll get to definitions and things that may or may not have changed in between in just a moment, but I just want to kind of zoom in and focus on just the critical parts of this before we start breaking it down, so people begin to understand why some would have said that this wasn't working. And so let's talk about those individual mandates.
Right now, the individual mandate was part of the law. It is no longer the law of the land. So up until this past December 31st, everyone in the country under the law was required to carry health insurance or pay a penalty. There, of course, were some exceptions to that rule. People who live in states where the Medicaid law was not expanded, like Florida. If you would qualify for Medicaid under the law, which was approved in about half the states, 36 states, you would have to sign up for an insurance plan or Medicaid or pay a penalty. If you lived in a state like Florida, some of the states connected to Florida, we call them the red states, many of them did not expand Medicaid, and if you did not get insurance because the state didn't expand Medicaid, you wouldn't pay a penalty. So they were exempted from that. Right now, you are no longer required to have health insurance in the country. We don't yet know, I'm optimistic, Allison's not, we do not yet know if that is going to destabilize the markets, because understand how insurance works. When someone gets sick, everybody who has health insurance, who's healthy, is paying for the person who is sick, right? My premiums, I've been lucky, I'm going to be 50 years old, I've never had a catastrophic illness. So my premiums that I'm paying and my employer's paying on my behalf fund the neighbor, whomever, who does get sick. Now people say, that's not fair, why would you do that? Because that's how insurance works. We all pay into a fund of money for the benefit of whomever needs that fund when something bad goes wrong. Hopefully that'll never be me. I would consider myself lucky if I paid into insurance markets my whole life and never needed the benefit. But it's certainly nice to know that it's there, because no one ever knows who's going to be the person who gets sick. Is it going to be me? Is it going to be my spouse? Is it going to be my friend, my child? So that's the whole underpinning of health insurance. So if you take away the mandate that says not everybody has to participate in this insurance market, the assumption of many is that people who are healthy will not buy the insurance, and that will have the effect of only allowing sick people or having sick people get health insurance, buy health insurance, which then means for the insurance companies to sell the insurance, because they have to sell it, the premiums will rise. So the individual mandate, not having that in place, people are worried that you are taking a healthy segment of the population out of the insurance markets, only leaving sick people or more sick people in it, and destabilizing the balance that people use to price health insurance premiums. The difference that Allison and I have, or I'm more optimistic about than not, based on callers to our radio show, is that we find that people want to have health insurance. The stumbling blocks from people for not having health insurance, I don't believe is an individual mandate. I believe it's the cost. So as long as people can still find health insurance, which is harder now than it's been, right, and as long as they can afford to pay for the health insurance, which is also harder than it's ever been, they will, I believe, continue, and I hope they will continue to buy the health insurance. I don't believe the penalty, the mandate, if you will, is a strong enough detriment to get someone to not buy health insurance. Now, I may be proved wrong. Allison may be proved right. We'll see.
What do you have to say about that, Allison?
No, I mean, again, this is like that's always the debate. Are people over the course of the last several years, have people gone onto the market and are they buying insurance because of the mandate? Is that the only reason motivating them to buy insurance? Healthy people, are they buying insurance because they have to buy it? And we'll see. I mean,
I don't know what the statistics are, but remember, the penalty started out really small, so
It
I don't
did.
think it was a big motivating factor for most. I think most people said, oh my God, if X, Y, Z happens, I'm not going to be able to afford a $20,000 hospital bill. I'd rather pay $5,000 in premiums because now it's available to me.
True, but that was 6 or 7 years ago,
Sure.
and premiums have gotten so much higher in
Right.
certain markets.
Well, the penalty's also gotten higher as
Exactly,
well.
but right. So, and this is the debate we have every day.
And there you go.
Usually
There you
the
go.
two of them
Exactly.
are on sides,
And that's
I'm
why
kind
we
of
got
So
them
if
like
you're young
this.
and healthy, and now you have to pay, $20,000 a year to have a health insurance plan, and do you take that gamble? And these are the calls that we get all the time.
Dee Dee, this was to me the individual mandate was never really about healthcare reform. It was really about politics, and it was an easy way for people who were against any change in the legislation, people who were against the healthcare reform, for whatever reasons they were against it. They thought it was too expensive, that it was government intervening in areas that they shouldn't have intervened. It became an easy target. In true substance, though, it really, it's probably the least significant piece of what the legislation had intended to, needed to and intended to accomplish. It sort of put the bow on the box to say, okay, we have the new health care. People are going to want it. People are going to need to have it. But let's just make sure that they do it. And it became a rallying cry for people who were against healthcare reform, and quite frankly, a very effective rallying cry, when in reality, it probably could have been done differently without causing such controversy.
Mm-hmm. Now, here in Florida, according to research that we were able to kind of put together, we found that the people here who, or at least, or I should say, are more than likely to be uninsured are those who can't afford it and or those who are simply too young to get Medicaid and Medicare. So that was according to the numbers and the information that we were able to get. I want to move along now to some of the other definitions that may or may not have changed between what happened in 2010 with the ACA and, of course, what just happened in 2017. So if we can go ahead and take a look at some of the definitions on the screen, then we'll be able to just start going down the list and see what kind of changes happened here. The healthcare, or I should say the health insurance marketplaces, the insurance exchanges, just off the top there, any of those just kind of jumping out at us and just saying these absolutely changed, something happened here with some of these? I could go down the list.
The exchanges and the marketplaces
Okay.
are essentially the same thing.
Okay.
What I would tell you is that the exchanges run better than they did when they first came out. This was a transformational event in our society when the law was passed. It was a bigger transformational event when they tried to actually launch the exchanges, and they needed more time. The technology that was involved was unprecedented to be able to implement a marketplace where people could go out and buy insurance in all the states. So it was just really mismanaged, further enraging the people who were against the law. See, they can't even make the insurance exchanges work. Well, 8 years later, it works. 6 years later, 7 years later, they work. What's changed is the products that are sold on them. So many states, in many states, there are some parts of the country, counties, cities, where there are no health insurance plans available on the exchange. In New York, where we come from, there are plans that have gone out of business, went bankrupt, that are not there anymore. So depending on where you live around the country, we get, I'd say, Allison, Matt, would you say more calls from North Carolina than any other state on our show? They only have one option, and people are really upset about it. So what are people frustrated about? What's changed? Fewer options, and for many, particularly adults who want to retire before they're 65, but are older than, say, 45 to 50, so people work their whole lives. It's not uncommon for people to say, I'm 60 years old, I've saved enough money, I want to retire early, enjoy, I don't know how long I'm going to be here, so I want to enjoy my life as much as I can. And they're going on to the insurance exchanges and finding out that a policy that they thought would be $12,000 or $14,000 for them and their families or their spouses are costing $25,000.
Let's go into some of these other definitions too, Andrew. Here we have subsidies, individual mandates,
right,
which we've already talked about, penalties for not buying insurance, Any of these jumping out? State-operated health exchange.
The subsidies are still in place, and they're still working. More states have expanded Medicaid. Arizona, very conservative. Well, it's not as conservative, but it's a conservative state. Republican governor, 2 Republican senators, they expanded Medicaid. So I think you saw more states that initially came out and said we are not going to expand Medicaid. So I think that was a nice change. The subsidies are the same as they were. In fact, something that this is an extraordinarily complex concept that I'm going to try and make people understand as best as we can. The more the current Congress destabilizes the health insurance marketplace, so when we talk about eliminating protections and individual mandates, and we talk about rising premiums as a result of that, because the subsidies are still in place, it actually costs the federal government more money to subsidize people because they're destabilizing the markets. So if insurance premiums go up, and they are, and the subsidies are still in place, the subsidy is for a higher dollar amount because the premiums are more. So who funds the subsidies? The taxpayers, the federal government. So when we have Congress fighting with each other, destabilizing the insurance markets, and insurance companies pulling out of the insurance exchanges, raising the prices for whomever stays in the marketplace selling insurance, it costs the government more money. It has the opposite effect. So we have a Congress right now that's controlled by the Republican Party that would like to see healthcare reform replaced because they think it's too expensive or whatever the reasons are. In fact, what they're doing is increasing the cost to the government because they're subsidizing higher premiums.
And you'll never hear about that.
And you will never hear about that.
This is a very complicated topic, right? But it is so important, and nobody will ever talk about this, right? And this is like a linchpin item to how the system is financed. And no one will ever talk about this. We talk about it on the show, and we try and explain it to people, but it's really complicated to understand. And in essence, it's just spending more, right? And people don't realize that. So it's pretty
We love
crazy.
when we have a studio audience come and listen to us, because when you're on the radio, you don't really see who's listening.
Who the people are.
But one of the things we have found along the way is many people don't really want to focus on healthcare as a subject matter to understand it unless there's a reason to, or they're immersed in a specific problem with their family, or they can't find health insurance. But if you're working and things are going well and you have health insurance for your job, the last thing you're focusing on is health insurance. It's only when people retire and they're not going on to Medicare yet, and they say, oh, I'll just get health insurance when I retire, or, and they realize that how big of a problem they're going to have, or they lose their job, or they become disabled. And that's who's calling our show. People who thought they didn't need to worry about it, and in fact, they do. It's a very complicated subject. It's a very difficult topic to talk about, and that's why we love when you invite us down here to give us a chance to do it, because we think it's so important for people to hear about.
And obviously, we think it is too, Andrew, and we're so happy again to host you all here on The Aware Show. And we want to make mention that we do have a live audience here for the show this time, because we did want to find out from some of our viewers what they're thinking and what questions they may have for you all. So we wanted to host this healthcare forum and give them an opportunity to kind of show up and say hello, and also just to ask their questions. And so we'll be going to them in just a moment. If any of you have any questions for us this evening you would like to ask either Matt, Andrew, and or Allison from Doctor Radio, Sirius XM Health Connect, we will certainly open up the podium and the mic for you to do that. There's just so much that you could talk about. I mean, it's almost like, I'm glad you all do the radio show, because it's something that's just ongoing. People always have questions. They always want to kind of tailor things to what they're going through and how it's impacting them. And that's kind of like why we wanted to do this in the broad sense, what's going on and how people are being impacted. Want to talk a little bit about, we're talking about what the costs are and that kind of thing, and the mandates and the things, the pressure that people have on them. But what's the pressure if you don't have insurance? What are the implications for people who are uninsured?
Well, there are the people who are uninsured, and there are people who are underinsured. Sure. So I consider those two people in the same category. So, what's sold on the exchanges now, and what people are rightly and justifiably so complaining about, are these high deductible health insurance plans. And these are plans that pretty much are the only plans a lot of people can afford on the marketplaces. They're either out of the subsidy range or even with the subsidy range. If you have a nice subsidy and you are covering 80% of your healthcare costs and that leaves you with $150 a month premium, well, to some people watching the program tonight, that may not seem like a lot of money, but to many people in this country, $150 out of their monthly paycheck is the difference between groceries for two weeks or 3 weeks. So being underinsured and having a high deductible plan, which we believe is better than no insurance, can be extraordinarily scary for people who actually get sick. Because if you have any medical event, you have your appendix burst and you need to go to the emergency room, that's a $30,000 hospitalization, even though you're out of the hospital the next day, right? So if you have a $7,000 deductible or an $8,000 deductible, where's that money going to come from? And that's what a lot of people have on the exchanges. If you have no insurance, you're not talking about a $7,000 deductible, you're talking about a $30,000 hospital bill that there's no way you can pay.
Right. And so that leads me to the main deal here, because a lot of times people think, well, I have insurance, this isn't a big deal for me, but it is when we start talking about the dollars and cents that the hospitals have to come to someone to pay that. Yeah. I mean, they have to stay open and available. So there we go to the next question. What is the implication for those who say this isn't a matter of concern for them, when in fact we know it is?
They are sorely mistaken.
Okay, let's talk about that.
I mean, so all three of us actually have had, luckily, only one, I think, each, acute illnesses that we had to go in and get something taken care of, and we moved on with our day. But we all had insurance, and it cost us, a couple bucks. If we didn't have insurance, listen, we were all healthy one day and woke up the next day and we're not healthy. And it would have set us back, no joke, probably over $50,000, right? That's a simple, quick, acute onset illness, right? But if you come down with cancer one day, and it happens, right? People are fine one day, the next day they have cancer, that's a $300,000 bill to get yourself taken care of.
Or more.
Or more. Most of us don't have $300,000 sitting around. So what do, right? You either don't get the care and you get really sick, and then you're in real trouble, or you get the care and they're going to come after your house, right? I mean, this is what hospitals do, right? They don't just provide the care and say, okay, well, we'll write that off.
Right.
Now there are great charity policies and charity care that's given, but these are big bills that people have to absorb, and we see it every day.
And go ahead, Alex.
I was going to say, and these are the calls that we get every week on the radio show. So most people, when you do have, at least we always say, get some type of a plan. Even if it's all you can afford is the highest deductible plan, whether it's a bronze plan on an exchange, it has the $7,000, $8,000 deductible. That's all that you can afford. Get the plan, and then if, like Matt says, you do end up in the hospital, whether it's an acute emergency situation or something that happens, you get a diagnosis and you do get admitted to the hospital for some type of long-term treatment, most hospitals, most doctors, they'll work with you to pay off some type of payment plan, some type of financial assistance program to pay off whatever that deductible is. But you need to have that conversation up front. Hospitals do have a charity care policy. Be up front and have that conversation with your healthcare provider, but don't ignore it. Don't get the bill and it's not going to go away.
Right.
Don't put the bill, in a drawer somewhere and ignore it. You have to have that conversation.
And Dee Dee, where you live matters. So,
yes.
With this most recent tax reform package that turned into law, which turned into a health care mandate, which I still don't fully understand how that has anything to do with tax reform. But, certain states, the higher tax states in this country, the reason the northeastern, the western states pay higher income taxes and property taxes is because these states are funding protections in healthcare that you don't actually enjoy in Florida. So in New York, for example, we expanded Medicaid. Florida did not. So immediately there is a segment of the population who, if you were living in New York, would get health insurance, and because they choose or don't choose and just happen to be in Florida, they don't get it. We have consumer protections, disclosure rights about getting services billed out of network, which means if you go to a hospital and the doctor doesn't take your health insurance, in New York, if they don't disclose that to you up front, and if you're not made aware of that fact, even if you're lying on a stretcher about to go into the operating room, if you are not informed of that issue, that the doctor you're about to see is out of network and you're going to get a bill, you don't have to pay that bill. We have insurance products in New York and California and other parts of the country, higher tax states, that are above and beyond the Medicaid protections. So the bare minimum of Medicaid expansion, if you live in a state that expanded it, gave consumers up to 133% of the federal poverty level to get health insurance. In New York, they actually raised that bar to 200%. And that's funded by higher taxes on the people who live in that state. So the law, the new tax law that just passed, which impacts the residents of those states who, with the deductibility of their taxes, their state and local income taxes, in fact, make it more expensive for people to live there than it already is, and further erodes the state's ability to be able to provide the extra protections that people who live in New York have that you don't have here. So when we get a call on our show from a parent who's concerned about their child who can't afford health insurance, who would qualify for health insurance in New York, but they don't qualify in Florida, our only advice to them is move to a state that has it. That's not really good advice.
Wow.
But that's the only answer to that problem. Move to a state that has those protections.
Who wants to move from Florida? No, just kidding.
What's a shame is that was the intent of the Affordable Care Act in the beginning, was to level set the access to health care, so everyone on a national level would be able to get the same level and the same type of care, and that's not what happened. So they left it, they did leave something to the states to decide. So unfortunately, we still have, what we always used to say is like good states and bad states to get health care, and we're going back to that. I mean, it never really got there where it was intended to go, and it's still eroding back to that level where even worse where it was before, unfortunately.
I see.
So.
You guys, you have no idea how time is flying right about now. I want to get to a little bit of information about you individually, and I know that it kind of parlays into what we're doing here this evening, because I do want our viewers to know why we chose you all to come and be here again on our show. Can you tell us a little bit about your expertise and what you do, and of course, Sirius XM Doctor Radio and your program, Health Connect, since we keep alluding to your show and that sort of thing. Tell us a little bit about it. We'll start with you, Andrew.
Okay, well, we all have full-time day jobs, and then we have our radio show and website as a hobby. During the day, we all work for NYU Langone Health System, which is a 4-hospital health system in the New York metropolitan region. My entire background for the 19 years I've been at NYU and all the years I've been in healthcare has always been in what we call ambulatory care, which is outpatient healthcare. So people always say, what does that mean? In its most simple way of saying it is, we run a doctor's office. So when you go to your doctor's office, we're responsible for running that doctor's office. And all of us, and some of our colleagues in the studio audience here tonight, play a part in that. What makes it slightly challenging and different is that we have 2,500 employed physicians. We have 7,000 employees, of several hundred who work actually in Florida. We provide the outpatient care to the patients. And the concept behind ambulatory care is to keep, as healthcare technology has changed, depending on where you live in the country, many hospitals have closed because something that you used to go to the hospital for a week, you now only go in for a day. So Matt was talking about hospitalizations that we've all had. I had an appendicitis attack. I was in the hospital for a day and a half. Now you go home the same day. 5 years ago, you would be in the hospital for a week. So there are the same number of hospitals that need to fill up their beds. So you have to have a wider network of physicians and patients closer out in the communities where they live to keep the hospitals full. So we actually run the physician offices in the network with the sole purpose of providing care closer to where the patients live so that they can avoid coming to the hospital unless it's absolutely necessary.
So from your job alone, you could get oodles of questions with what you do. And
We do. Well, that's what the radio show
Yeah,
is. I
sure.
mean, that's how we formed the radio show. People kept asking us questions in our jobs. We said, why don't we just talk about this on the radio?
Good deal. Matt?
So I work very closely with Andrew and his team, but my spin that I kind of took over in the last 2 years is a little different, and it's really about healthcare reform. So me and my team are really responsible for looking at healthcare reform and healthcare redesign and ensuring our patients are getting the best possible quality at hopefully the lowest cost. So we look at how we can keep patients out of the hospital, how we can find the sickest patients who need help, who need care coordination, and we have a team of nurses that call those patients and make sure they actually don't come in the door. And actually we get them to Andrew's doctors in the hopes of keeping them in the outpatient setting rather than the inpatient setting. And we look at all of those high-risk patients and try and bend the cost curve, we call it. The old healthcare saying is that 80% of the healthcare dollars are spent by 20% of the patients. It's really probably 5% of the patients spend 90% of the healthcare dollars. And our team is looking at those 5% of the patients and how we can improve their quality and hopefully reduce their cost and their utilization.
This is the sexy part of healthcare reform. What Matt is doing and leading is really what every hospital system, Matt's sort of in the forefront of this. We are much further ahead than many other hospitals around the country. Matt is leading the team and the charge in terms of transforming how we look at healthcare. So the technology, electronic medical records that we have available to us now that we didn't have available to us 6 or 7 years ago. Data that we get from the insurance companies that they didn't have 6 or 7 years ago allows people like Matt and his team to work with our physicians and our patients directly to keep them healthier. And that is a huge change in the healthcare system. And it's one that is never spoken about because why would you talk about it if you don't work in it? But in fact, it's as simple as when you get discharged from any hospital now, you get a series of phone calls to make sure that you're taking all your medications. If you're not taking your medications, someone may be dispatched to your house to help you make sure you take those medications because we don't want the patients to come back. And what he's doing is really cool stuff.
Good deal.
I appreciate you.
Allison, tell us a little bit about what you do at NYU Langone.
So I've been at NYU for 16 years now, and what I do is I work with all the managed care with the commercial payers. I negotiate our contracts with the payers. So I negotiate the rates that our employed physicians get paid. So whenever we have a patient that comes to see one of our doctors, what we get paid for an office visit, for surgery, all that exciting stuff. So in addition to negotiating our contracts, I also work with all of our 2,500 physicians. And that, that compromises, we have 200 physician offices or a little over of that now. So all of those points of care where our patients actually access services, those patients need referrals and authorizations to actually get their care. So whenever we have problems, because, insurance companies never screw up anything like that. So whenever our practices have issues on an operational side and they need help facilitating care and accessing care for our patients, if they have issues, with the payers, they'll come to our department, to my department, and my team will help facilitate any operational issues with the managed care. So we have, any patient access issues will go through the managed care department. So we work on all those issues for that and any problems with credentialing our doctors with the commercial payers and getting all that stuff resolved. So
when Allison first joined NYU, I had heard she was coming and we desperately needed her skills. And I was so excited. I hadn't met Allison yet. Other people had met her. And, we've been working together, 16 years. And we never had anyone in that role prior to Allison's arrival. So she came to meet me for the first time and she walks in the door. I was so excited to meet her and we were going to change how we work She showed up 8 months pregnant.
That's true.
Ready to go on maternity leave.
I was there for
and
3.5 weeks.
weeks later,
Yep.
she was gone.
Wow.
But I came back.
You did.
And then I had 2 more kids. But then I kept coming back.
You did.
All right, there you go. That's wonderful. It's just one
my
big
favorite
happy
Allison
family. I
story.
see. And so all this, of course, as you mentioned, Andrew, parlays into your program that you do on Doctor Radio, Health Connect. Tell us a little bit about that, and then we'll want to get into some of your, I don't want to say most unique calls, but some of the calls that you all do take on your program.
So HealthCare Connect started, it'll be 10 years in March. There is a channel on Sirius XM Radio, channel 110. It's called Doctor Radio. One of our patients is the president of Sirius XM Radio. And he had this idea that wouldn't it be great if he could get some of his doctors onto a radio show to have people call in and talk about their various healthcare conditions. And I thought it was a crazy idea for a channel. I didn't think anyone would want to listen to it. And people I work with at NYU, the guy I work for was put in charge, a physician, he was put in charge of putting the radio show together, and because I was at the time and still am sort of his operations guy, he asked me to help put it together. And I said, why don't we pilot a show on health insurance? It's Doctor Radio, why not have people be able to call in and ask questions on problems they were having getting insurance claims processed, signing up for Medicare, the difference between an Advantage plan and a Medigap policy. Is traditional Medicare better than an Advantage plan? What do I do if I can't afford my bill? Open enrollment is changing my benefits every year. Should I take a high deductible plan, a low deductible plan? All these questions started popping through my head. I said, why don't we do a show once a month? So he pitched it to the radio network, and they liked it. So we started out, the concept was once a month. And after our first show, the producer said, this would probably be better if you did it every other week. And then we did it 2 weeks later, and then he said, the show would really be better if you did it every week. So we've been every week, and we play 4 times during the week for now 10 years. And all we do is answer the questions I just said. And they never stop coming, Dee Dee. They never stop coming.
And I'm not surprised because, as I mentioned earlier, people have questions individually, and it just keeps going. So, talking about some of the questions and the things like that you all get on the air, do you have something that just pops up to mind that perhaps would be for the broader scope of people,
Sure.
something that people ask?
I would
most
say
often?
it's interesting. One of the things, and I think it's important to preface this, that everybody's circumstance is different and unique. So while
important to them.
And important to
Yeah,
them,
sure.
and always has a thread of information that changes the sort of the canned answer we have. Because we also do emails throughout the week, so we get emails, and we always talk about we should just have a set of canned email responses that we could use, but it never works. Because if we're answering 100 emails a week, which is about what we answer, there are always different responses, and I know I shared with you some of those emails.
Yes, interesting.
But I think one of the themes, looking at the studio audience, that I think is relevant is understanding, particularly seniors, understanding their Medicare benefits, whatever component of it that they don't understand. So there are many people who are still working, so they want to know if they keep working, can they keep their health insurance? Do they have to sign up for Medicare? If they don't sign up for Medicare, do they get penalized even though they have health insurance and they're still working? A lot of people don't understand this concept called Medigap, secondary health insurance, that you can only buy it 6 months after you turn 65 and first enroll in Medicare. And if you don't buy it in the first 6 months of your Medicare enrollment, you never get a chance to buy it again. And people say, I'll just buy it later. But you can't buy it later, and people don't understand that. So lots of questions about what is Medicare, what do I need to do to sign up, what if I don't sign up, what if I miss the window, all those kinds of questions. What if I don't like my Advantage plan, what is an Advantage plan?
But we do go through like this natural cycle. I think Medicare is always a question we get, but it does kind of go like cyclically, right? So we get some open enrollment questions in November and December and even early into October, right? And then you get into Medicare Advantage now because you can make some changes. And then anytime something happens in the news, we have like a month of newsworthy stuff. But Medicare always is in there.
And I feel like I should be asking you that so that people understand Medicare, Medicaid, and all that you're talking about.
We're not on Medicare yet. Is that what you're
We're not there yet.
We're not on Medicare.
We only have a few minutes left in this segment, so we got to get in what we can get in.
We can talk about we're not signed up for Medicare.
I see. Of course not. Much too young for that. Let's talk about some of the impact all of this would have on our elderly, because you just mentioned some of that with of course, with what we were talking about. Deep concerns for people who, as I mentioned here in Florida, who may or may not be at retirement age to the point where they can get, they may be at retirement age but can't get Medicare and Medicaid because they're not old enough yet for it.
They're the people, I think they're the segment of the population is currently and will continue to struggle the most in the country. We had a caller this past Thursday. She was 56, her husband was 54, she was a nurse, and she wanted to retire in the next 2 years, so she'd be 58, her husband would be 54, 56, whatever the numbers were, but far enough away from Medicare that, and I asked her the question, I said, are you planning to have and spend $20,000 to $25,000 a year on your health insurance? And she paused, and then her answer came back with no. I said, and I said, well, it's not really my business to tell you this, but you can't retire.
Right.
So
unfortunately, the answer always is, and we have this way too often, is you got to keep working, right? You're going to have to bridge the gap. Like, yes, we all dream of retiring early at 55, but you got to bridge the gap until 65 because the premiums today are just going to be too high.
Take everything you've worked for.
That's right.
In your
All
retirement
your
to pay your
funds are going away.
If you have a
That's right.
retiree health plan, benefit plan, or money set aside for that, specifically for your health plan, before Medicare kicks in. This is the situation.
Many employers used to offer retiree health benefits, and I'm sure there are people in the audience today who have retiree health plan benefits through their employer. Many employers have changed the benefits.
Yep.
So where you used to have a secondary policy to your Medicare benefits that allowed you to go anywhere, now they're saying, well, we're not going to pay for that anymore, but you can sign up for an Advantage plan, something like that, which in many cases has a restrictive network of doctors and hospitals you can see, and people where they used to think they had access wherever they wanted to go are now restricted to a specific network. So even people who thought that they had made it through and had reached, the golden age of retirement with a good retiree health plan find that, there are changes to the system. And those are very difficult, issues for people to deal with. They made assumptions about how they were going to spend their retirement years, and now they're finding that they did everything right. They worked, they followed the rules, they paid their taxes, they paid into their employee benefit plans throughout their careers, and they're finding out the rules have changed. And it's very upsetting to these people.
It's like it's always something. You think one thing, and it seems like it's always something else.
Well, and for these, right, those 55 to 65, if you were to get your insurance on the exchange, premiums are really set on the exchange based on 3 factors: where you live, how old you are, and if you smoke, right? So the older you are, the more you're going to pay. That's just the fact of the system. So if you're 60 years old, you're going to pay a lot more than someone who's 40. And if you didn't budget it correctly, unfortunately, you're going to have to keep your employer's insurance until you can get to Medicare age.
Good. I want to get to some of the tax implications of all of this before this hour wraps up. I also want to remind our studio audience that you can step to the podium, and of course, we'll be happy to take your question here for our panel this evening. So let's talk about, just quickly here, some of the tax implications of everything that's going on between what has been passed from
Sure.
the American HealthCare Act of 2017.
So you can still deduct your healthcare expenses. That was stripped out in one version of the bill but ended up in the tax law. So you're still able to deduct your expenses. However, a lot of people don't actually, if you take the standard deduction, which most Americans will do, a lot of people won't actually be deducting their healthcare expenses anymore. So I would say that the impact is real to higher earning people, again, from the higher tax states where they were more often than not taking the standard deduction on their taxes. So I don't see that as a huge issue for the majority of the people who file tax returns in this country. Health savings accounts, which are fantastic tools for people to use tax-free money to invest and put money into an account tax-free to pay for future healthcare expenses. You actually can't do that if you're on Medicare, but up until Medicare, you can do that. That is still in place. So there was a lot of discussion leading up to the signing of the tax law, what was going to be included, what was not going to be included. The big showstopper from the tax law was the elimination of the individual mandate. Other than that, there was no major impact on this.
Okay.
But there are other changes that the president has ordered his administration to put in effect, and we probably won't have time to talk about this segment. Most recently, this past week, the second week of January, the Secretary of the Administrator of CMS, which is the Center for Medicare Services, Medicare and Medicaid Services, are allowing states to file demonstration projects to require people to work to receive Medicaid benefits. So I believe it was 10 states.
10 states, and Kentucky was actually approved today.
To require people to work to get Medicaid. There are very, very, very few healthcare experts in this country who will tell you that's a good thing. And that is enormously transformational. And as something I alluded to in the beginning of the show, of the program today, President Trump is allowing these, what they're called association plans, to be sold on the exchanges. And these are basically groups of like-minded people working in associations, writer groups and things of that nature. They will be able to go out and form insurance block groups to be able to provide insurance to members of their associations. The problem with those plans is that they do not offer the same protections as a healthcare reform Obamacare plan would. So you may find an association plan on the exchange for your group if you're in that association, and you may see a premium that's half the premium of other plans, but it may exclude coverage for a lot of different diseases and conditions. It will exclude you if you have pre-existing conditions, and they can, which means they can only take. They may only take healthy people.
And they also don't have the same requirements for reserves to make sure that they can fund all of these claims. So you could actually run into an issue where you have a claim and they say, oh, we don't have any money to pay that. And then you really actually don't have insurance.
But you're buying the product on the health insurance exchange, and you think you're getting a good health insurance product. But it's different. And it's not until you need it that you may or may not have the benefits you thought you were going to have.
So you may get cancer, but you don't have coverage for chemotherapy or ambulance services or things like that.
Buyer beware.
Exactly. You have to read the fine print on something like that.
Which leads me to my next question. How does a person know what they should do for themselves?
That's a great question. That's actually the best question. It's the best question you're going to ask all night. And I'm sorry, it's only the first hour. But we will tell anybody who calls the show or writes to us. As difficult as it is to understand a lot of what we're talking about, and we hope that we're explaining it in a way that people can understand. As difficult as it is, when you are making a decision for yourself, for your family, very often grandparents and parents for their children and grandchildren, because the population that's older tends to focus on this for obvious reasons more than the younger population, people who believe they're invincible to getting sick. Everybody needs to take responsibility for their health care insurance and access decisions. So I have many friends who are my age or younger, or some a little bit older, who are highly educated, very successful in their respective fields, who don't know the first thing about the health insurance products that they need for themselves, or what to take when it's open enrollment, or sometimes, in some cases, even what type of insurance they have. And that frustrates all of us to no end. So the answer to that question is, what can you do? You can read. If you're turning 65, you go on Medicare.gov. You can call us. You can listen to
Sure.
our radio show. Or you can go and do what people write into us, and we'll answer your question. We'll attach a link to the email that says, go to this webpage. It's the Medicare website. It's written for people in simple English, most of the time, to understand and answer their questions. But most people just don't do that. They just simply don't do it.
You just have to read, and actually take out a pad and pen and think about the worst case and do some addition, and you can somewhat get to the right conclusion most of the time. But you got to invest the time. We used to say people know more about the TV they're going to purchase than their health insurance.
Sure.
And you have to change that, right?
That's
You
good.
really have to take the time and read and understand it and ask people and search the internet, and you can actually make a fairly educated decision.
And if you're getting insurance through your job or through, you're buying it for yourself, if you're not getting Medicare, ask your doctors, do you take your insurance? Go to make sure your local hospital, the hospitals in your community, find out if they're in the network of the insurance you're looking to purchase.
Or a Medicare Advantage plan.
Exactly.
If you've, a Medicare Advantage plan, do we have time to talk about that now?
We have less than 2 minutes. You can go if you can.
I'll do it fast.
Okay.
Medicare Advantage is, it's Medicare, but it's managed by private health insurance companies. So it's very similar to the health insurance that working people have. So it's Medicare, but you tend to get all your services bundled together. So you pay one fee every month and all your health care is covered, and it runs the same way my insurance works, Matt's works, and Allison's works. The important part of a Medicare Advantage plan, and there are many people, and we should talk about this next hour, many people love it and many people don't like it. So what people like about it, if they live in an area where all the doctors that they want to see and all the hospitals take the insurance, they're going to find they're going to save themselves a lot of money. If you live in a certain part of the country where it's a restricted network, or you buy a Medicare Advantage plan that has a smaller network of doctors and hospitals, you'll be very frustrated if you want to go see a doctor or a hospital that's not in the network because you can't go see them. So, again, buyer beware. Know what you're getting.
Very good. Allison, Matt, you got anything else you want to add right quick?
Nope, I think that covers it for now.
Yeah, it's a good start.
It's a good
There's
start.
a lot more to go.
There's a lot to
but
learn
there's a
about
good
Medicare
start.
Advantage and traditional Medicare.
Okay, very good. All right. Well, we have another hour coming up in just a moment, but for now, that is all the time that we have for this half of our healthcare forum on the American Health Care Act of 2017. Hopefully, we've made you a little bit more aware of some things you may have been not so much aware of, and this will help you to make an informed and an educated decision about your healthcare coverage for you and your family. I want to thank our guests, of course, for joining us, Andrew Rubin, Allison Vogel, and of course, Matthew Penziner from NYU's Langone Medical Center and the host of Sirius XM's HealthCare Connect on Doctor Radio. Thank you, of course, for joining us in our studio, and thank you there at home. As always, be sure to join us for the second half of this program as we give you even more information on how you can find the right resources and how you can navigate your best healthcare options and choices. Meantime, you can always catch us on WSRE.org or on YouTube. We're always happy to see you there. I'm Dee Dee Sharp. Until the next time, stay informed and stay aware.